नमस्ते, हमेशा खुश रहो बेटिया। आई एम JV Dr. Meenakshi, Associate Professor in PG Department of Shalakya Tantra. In previous class, we have studied about the acute DACRYOCYSTITIS, which is a type of the adult DACRYOCYSTITIS, which is again is a type of DACRYOCYSTITIS. Today we will study about the another type of adult DACRYOCYSTITIS, which is the chronic DACRYOCYSTITIS, and it is more common than the acute DACRYOCYSTITIS. As we all know, what is DACRYOCYSTITIS? It is the inflammation of lacrimal sac. And chronic, it is a chronic inflammation of lacrimal sac is called chronic DACRYOCYSTITIS. So first of all, we'll study about the etiology of the chronic DACRYOCYSTITIS. The etiology of chronic DACRYOCYSTITIS is multifunctional. The well-established fact is a vicious cycle of stasis and mild infection of long duration. The etiological factors can be grouped as first, predisposing factors; second, factors responsible for stasis of tears in lacrimal sac; third, the source of infection; fourth is a causative organisms. So under the heading of predisposing factors, there are 6 points. First is age, second is sex, third is race, fourth is heredity, fifth is socio-economic status, sixth is poor personal hygiene. So there are 6 predisposing factors for causing the chronic DACRYOCYSTITIS. So first is age. It is more common between 40 and 60 years of age. And we talk about sex. The disease is predominantly seen in females, 80% probably due to comparatively narrow lumen of the bony canal. Third is race. It is rarer among Negroes than in whites, as in the former NLD is shorter, wider, and less sinus. The fourth predisposing factor is heredity. It plays an indirect role. It affects the facial configuration and so also the length and the width of the bony canal. The fifth predisposing factor is the socioeconomic status. It is more common in low socioeconomic group. The sixth predisposing factor is poor personal hygiene. It is also an important predisposing factor. The second etiological factor is the fifth predisposing factor is the socioeconomic status. It is more common in low socioeconomic group. The sixth predisposing factor is poor personal hygiene. It is also an important predisposing factor. Then we come to the second etiological factor, that is factors responsible for stasis of tears in lacrimal sac, which have again 5 points. The anatomical factor, second foreign bodies, third excessive lacrimation, fourth mild grade inflammation, and fifth the obstruction of the lower end of the NLD. Under the anatomical factors which retard drainage of tears include comparatively narrow bony canal, partial canalization of membranous NLD, and excessive membranous folds in NLD. The second is the foreign bodies in the sac may block opening of NLD. Third is the excessive lacrimation, primary or reflex, causes stagnation of tears in the sac. The fourth factor is the mild grade inflammation of lacrimal sac due to associated recurrent conjunctivitis may block the NLD by epithelial debris and mucus plugs. The fifth factor responsible for stasis of tears in lacrimal sac is the obstruction of the lower end of the NLD by nasal diseases such as polyps, hypertrophied inferior concha, marked degree of deviated nasal septum, tumors, and atrophic rhinitis causing stenosis may also cause stagnation of tears in the lacrimal sac. Fourth factor is the source of infection. Lacrimal sac may get infected from the conjunctiva, nasal cavity, that is retrograde spread of nasal sinuses. And the fourth main etiological factor is the causative organisms, which may be staphylococci, pneumococci, streptococci, and pseudomonas, pyocina. Rarely chronic granulomatous infections like tuberculosis, syphilis, leprosy, and occasionally rhinosporidiosis may also cause DACRYOCYSTITIS. When we talk about the clinical picture of chronic DACRYOCYSTITIS, it has 4 stages. Earlier, we studied the three stages of acute dacryocystitis, whereas in case of chronic dacryocystitis we have four stages. First stage is the stage of chronic lateral dacryocystitis. Second, the stage of lacrimal mucocele. Third is the stage of chronic suppurative dacryocystitis, and fourth is the stage of chronic fibrotic sac. Under the first stage of chronic lateral dacryocystitis, it is characterized by mild inflammation of the lacrimal sac associated with blockage of NLD. In this stage, the only symptom is watering of eye and sometimes mild redness in the inner canthus. On syringing, the lacrimal sac either clear fluid or few fibrinous mucoid flakes regurgitate. Dacryocystography reveals block in NLD, a normal sized lacrimal sac with healthy mucosa. The second stage is the stage of lacrimal mucocele. It follows chronic stagnation causing distension of lacrimal sac. It is characterized by constant epiphora associated with the swelling just below the inner canthus. Milky or gelatinous mucoid fluid regurgitates from the lower punctum on pressing the swelling. Dacryocystography at this stage reveals a distended sac with blockage somewhere in the NLD. Sometimes, due to continued chronic infection, opening of both the canaliculi into the sac are blocked and a large fluctuant swelling is seen at the inner canthus with a negative regurgitation test. This is called encysted mucocele. Stage of chronic suppurative dacryocystitis. Due to pyogenic infections, the mucoid discharge becomes purulent, converting the mucocele into pyocele. The condition is characterized by epiphora, associated recurrent conjunctivitis, and swelling at the inner canthus with mild erythema of the overlying skin. On regurgitation, a frank purulent discharge flows from the lower punctum. If openings of canaliculi are blocked at this stage, the so-called encysted pyocele results. Fourth is the stage of chronic fibrotic sac. Low-grade repeated infections for a prolonged period ultimately result in the small fibrotic sac due to thickening of mucosa, which is often associated with persistent epiphora and discharge. Dacryocystography at this stage reveals a very small sac with irregular folds in the mucosa. These were all the four stages of the chronic dacryocystitis. Then we come to the complications of chronic dacryocystitis. The chronic intractable conjunctivitis or acute or chronic dacryocystitis. Chronic dacryocystitis may cause atropine of the lower lid, maceration and eczema of lower lid skin due to prolonged watering. Simple corneal abrasions may become infected, leading to. The third complication is the complication of simple corneal abrasion may become infected, leading to hypercommon ulcer. Then the next complication is if an intraocular surgery is performed in the presence of dacryocystitis, there is high risk of developing endophthalmitis. Because of this, syringing of lacrimal sac is always done before attempting any intraocular surgery. Then we come to the treatment of the chronic dacryocystitis. First is the conservative treatment. Second is the dacryocystorhinostomy DCR. Third one is the dacryocystectomy DCT, and fourth is the conjunctivo dacryocystorhinostomy CDCR. These are all the four treatment procedures of the chronic dacryocystitis. First is the conservative treatment by repeated lacrimal syringing. It may be useful in recent cases only. Long-standing cases are almost always associated with blockage of NLD, which usually does not open up with repeated lacrimal syringing or even probing. Second is the dacryocystorhinostomy DCR. It should be the operation of choice as it re-establishes the lacrimal drainage. However, before performing surgery, the infection, especially in pyocele, should be controlled by topical antibiotics and repeated lacrimal syringes. The third treatment is the dacryocystectomy, that is DCT, should be performed only when DCR is contraindicated. Indications of DCT include too young, that is less than 4 years, or too old, more than 60 years patient. Markedly shrunken and fibrous sac, tuberculosis, syphilis, leprosy, or mycotic infections of sac. It may be done in tumors of sac. It can be operated in gross nasal diseases like atrophic rhinitis. And an important thing to remember is an unskilled surgeon, because it is said that a good DCT is always better than a badly done DCR. The next is the conjunctivo-dacryocystostomy. It is performed in presence of blocked canaliculi. In the previous lecture, we have discussed about the surgical steps of DCR, in which we uh, study two techniques: conventional external approach DCR and endonasal DCR. Now we will study about the surgical technique of DCT, that is dacryocystectomy. The first to four steps of DCT are same as the external DCR operation. In the first step, what we do first anesthesia. General anesthesia is performed, however it may be performed with local infiltration anesthesia in adults. The second step is the skin incision, either a curved incision along the anterior lacrimal crest or a straight incision 8 mm medial to the medial canthus is made. Third is the exposure of medial palpebral ligament (MPL) and anterior lacrimal crest. MPL is exposed by blunt dissection and cut with scissors to expose the anterior lacrimal crest. The fourth step under this is dissection of lacrimal sac. The periosteum is separated from the anterior lacrimal crest, and along with the lacrimal sac is reflected laterally with blunt dissection exposing the lacrimal fossa. The fifth step is the removal of lacrimal sac. After exposing the sac, it is separated from the surrounding structures by blunt dissection, followed by cutting its connections with the lacrimal canaliculi. It is then held with artery forceps and twisted 3 to 4 times to tear it away from the nasolacrimal duct, that is NLD. The sixth step is the curettage of bony NLD. It is done with the help of a lacrimal curette to remove the infected parts of membranous NLD. The seventh is the closure. It is done as for external DCR, in which what we did, the MPL is sutured for periosteum, orbicularis muscle is sutured with 60 vicryl, and skin is closed with 60 silk sutures. This was all about the surgery of DCT, the surgical techniques of DCT. In previous lecture, we studied about the acute dacryocystitis. Apart from the adult dacryocystitis, we have the congenital dacryocystitis, which is an inflammation of the lacrimal sac occurring in the newborn infants. Thus, it is also known as the dacryocystitis neonatorum. What are the etiology of the congenital dacryocystitis? It follows stasis of secretions in the lacrimal sac due to congenital blockage in the nasolacrimal duct. It is of very common occurrence. As many as 30% of newborn infants are believed to have closure of nasolacrimal duct at birth, mostly due to membranous occlusion at its lower end, near the valve of Hesner. Other causes of congenital NLD blockage are presence of epithelial debris, membranous occlusion at its upper end near lacrimal sac, complete non-canalization, and rarely bony occlusion. Common bacteria associated with congenital dacryocystitis are Staphylococci, Pneumococci, and Streptococci. Then we discuss about the clinical picture of the congenital dacryocystitis. The congenital dacryocystitis usually presents as a mild grade chronic inflammation. It is characterized by epiphora, regurgitation test, swelling. Epiphora usually develops after 7 days of birth. It is followed by copious mucopurulent discharge from the eyes. Regurgitation test is usually positive, that is when pressure is applied of the lacrimal sac area, purulent discharge regurgitates from the lower punctum. Swelling on the sac area may appear eventually. Then we come to the differential diagnosis. Congenital dacryocystitis needs to be differentiated from other causes of watering in early childhood, especially ophthalmia neonatorum and congenital glaucoma. Then we come to the complications of the congenital dacryocystitis. When not treated in time, it may be complicated by recurrent conjunctivitis, acute or chronic dacryocystitis, lacrimal abscess, and fistula formation. This was all about the congenital dacryocystitis. In the next lecture, we will study about this in very detail, so that the overall concept of dacryocystitis can be studied. Thank you so much.